It's my privilege to be able to share with you information about sinus augmentation and considerations for dental implant therapy. I do practice periodontics 5 days a week in private practice. We've got several branches around the Puget Sound area. I'm also on faculty at the University of Washington, and I keep my position at the Graduate Periodontology Department at Temple University. I do have to read this disclaimer. My apologies. Legally, I want you to know the information presented at this program represents personal opinion. Reasonable efforts have been taken intending for educational subject matter to include various publications and clinical cases shared with permissions from other providers. However, each of you as a program attendee should always use your own personal and professional judgment when considering further application of any of the information you see here, particularly as it may relate to patient diagnostic or treatment decisions, including, without limitation, any FDA-approved uses or off-label uses. Thank you for bearing with me there. I did want to recognize and thank Nobel for sponsoring me and giving me the opportunity to come and share this information with you this morning. I also want to recognize and thank the Hugh Frady Group, who will be providing the instruments for the hands-on portion or the demonstration, and we'll actually have a surprise hands-on exercise at the booth demonstration on Saturday at 11 o'clock. I've taken a lot of the information from a summation of our chapter from the Contemporary Implant Dentistry textbook by the late Professor Carl Misch, recently republished by Professor Randy Resnick. I had the privilege of teaching with the Misch Institute for many years, which is now the Resnick Institute, which is in charge of publishing this textbook. So it's been a culmination of all of our faculty collaboratively putting the information together. So if you're interested in more references and information about sinus augmentation in conjunction with implants, I would direct you as one opportunity to learn more here. Briefly this morning, I just plan to address topics of rationale for why we consider it, what we do about it, briefly some pitfalls with pathologies. I'll show some of the techniques we have available at our disposal. And of course, I want you to understand that when we're treatment planning implants, especially in the posterior maxilla, I think the sinus deserves a profound level of respect and consideration because it dictates how we can place implants, what type of complications we can have, what types of techniques we might do to employ with our treatment planning. This is actually an older CT scan over here. Back in the day when we used to have films, you had to print them out. They had little hash marks and you had to put your handmade stents in. When I was a student, I didn't have a lot of money, so I did an acetate suck down with, believe it or not, clear fingernail polish and barium sulfate. So that's old school. We have much better techniques now. But just to give you a sense, sinus issues have not been something we've always been so familiar with treating. It's only been in the last 30, 40 years that we've had techniques to really be able to predictably deal with them. So if we look at the posterior maxilla bone considerations in this particular patient, we can see that the bone is bordered by the crestal bone on one side, by the inferior floor of the sinus on the other. We've got the sinus space we have to negotiate and worry about. We'll consider placing the implants. We want to make sure that biomechanically we place implants large enough, long enough, have enough surface area to separate, to be able to support the biomechanical forces of treatment planning there. And so what we want to avoid is situations like this. I often get referrals with patients that have implants placed where there was no sinus lift even attempted. And so if you look a little bit closer at the periapical film here, you can see basically we don't have any bone in the apical half of this implant. You can also see that I think there's biomechanical bone loss in some remodeling starting at the crestal aspect. And so what we have here is essentially a seesaw. We've got off-axis forces and we've got bone loss, sinus pneumatization. Believe it or not, this patient was quite symptomatic. They came in with a chronic sinusitis that had been present for years. Does anybody think this is a standard of care that we should be upholding? Right? So there's some of the horror stories that we can run into if we don't respect the sinus cavity. So a couple of things just to set our bases. All of us learned about the lining of the sinus, the Schneiderian membrane. I always thought it was really fun to say that word when I was a resident and sound like I was smart. We know that normally on the radiographs, on CT scans, when we look at cross-sections like this, the right side represents health or a sinus that's completely clear. The left side, that's no bueno, right? We don't want to see any type of radiopaque thickening. It's considered abnormal. Anytime you have a scenario where you have two surfaces of the Schneiderian membrane touching and the sinus, that asks and invites a whole host of problems, a high incidence of pathology. We know that the pseudostratified ciliated columnar epithelium that lines the sinus, that's contiguous with the nasal cavity, produces and drains up to 1 to 1.5 liters of mucus every single day. So if we do anything to inhibit or interfere with that mucociliary clearance, that also is inviting a host of problems. It's also not necessarily as great of a vascular reservoir as we think. There is vascularity to the sinus, but it's not as robust as other surgical sites in the mouth. This is one of the rationales why we have to institute antibiotics at least starting a day before surgery when we consider sinus lifts in this area. If we think about some of the anatomical issues, we know with the lateral wall, that's our main point of interest in entry, with much larger techniques for lateral sinus augmentation. We know that it can often have variable thicknesses. When we're reflecting a flap, we know that we have to pay attention to the endosseous anastomosis of the infraorbital artery and the PSA. We know there can be branches that are both extra sinus and infra-sinus existing, or intraosseous and extraosseous. And so we have to make sure that we don't encounter this or we don't perforate through that structure. If you do, it really slows you down, right? You have to take time and consideration to stop it. The other thing I would encourage all of you to think about, we now consider it a standard of care to take a CT scan any patient that's getting an implant in the posterior maxilla that might need sinus considerations. And so it's really important to make sure you take the scan high enough. A lot of our new assistant hires, I always have to train them to say, make sure you take the sinus high up so you see the inferior orbital rim, right? You should almost see the border of the eye. And the reason for that is you want to pay attention to the osteomeatal complex. If it's not patent, or what we consider open, then that's also inviting a host of sinus problems and complications. You want to make sure there's appropriate mucociliary flow and clearance. And so a couple of pitfalls, and I won't spend a lot of time on these, but just common things to know about. We can have sinus issues that are both inflammatory in nature, that are odontogenic, non-odontogenic infections. There's various anatomical variants to be aware of, various cyst conditions, very rare but serious fungal infections, neoplasms demonstrated by expansive lesions, or foreign bodies. So our group out of Temple University published this review not too long ago. You might find it interesting to know that about 1 in 4 patients in the general population exhibit some type of sinus pathology. That's pretty high. That means we have to pay attention to make sure we have appropriate visualization and appropriate exam. We also know that almost half of patients exhibit some type of sinus septa. Those also require very careful negotiation during surgical approaches. In addition to that, we know that there's a significant number, over a third, of sinus pathologies are related to odontogenic infection. So it's important, of course, to look at teeth that have root canals, possible periapical lesions, anything that could expand into that sinus cavity or be in proximity to it. And then up to 84% of patients, the significant majority, are going to have that anastomosis structure that I alluded to earlier. And so just a couple of examples clinically on what we're looking for. The far left here represents health, or what we like to see. You know, the middle image there shows some slight thickening of the Schneiderian membrane. At the same time, that's still considered clinically healthy and acceptable to proceed. The far right side there, this could be a host of several different things that are both problematic and need additional treatment or management. Usually what we'll do is partner with an otolaryngologist. So just an example there, you can see some of the thickening just to the floor. That's not too significant for me, but you'll also notice there is periapical infection on that tooth. That is a significant consideration that requires planning around. A couple other examples here. There's various polypoidal conditions on the top 3 images there. Those are all various types of polyp conditions that are very resilient. They're hard to treat. They don't always go away predictably. Even if we refer these patients to an ENT to try to manage, they have a preponderance to come back. You can see on the lower left side there, air fluid levels that are very significant. That middle image is a completely opacified sinus. Definitely don't want to be putting an implant in there or doing a sinus graft while that's going on. And then foreign bodies on the foreign right side, lower right side there. And just as a reminder, again, we have up to about a quarter, or 1 in 4 of our patients will exhibit some type of pathology or abnormality. Again, that's from our study at Temple University. In terms of benign conditions, one of the most common things you'll see is like a mucus retention cyst. We usually don't require too much consideration of this unless it's getting in the way of where we're going to be entering with our window. Also, remember I mentioned that if you have 2 layers of that Schneiderian membrane touching each other inside the sinus, that also can invite infection or postoperative complication. So that does require some consideration, but they're usually very benign. The right side over here are 2 different examples of things you definitely don't want to treat these right away. You have to send them to an ENT first and get clearance, or sometimes it might be a contraindication. They may not be appropriate implant candidates. If this is very overwhelming, that's because this represents all of the updated diagnoses in periodontology. I'm not going to go through all of these, but just to kind of remind you, in 2017, the American Academy of Periodontology and our European colleagues updated and reclassified all the various periodontal conditions and implant conditions and diagnoses that we had been familiar with. The last time they had published these wasn't since 1999. And so this basically grid here represents various committees of anywhere from 10 to 20 periodontists that spent several days. They deliberated in Chicago. The meeting took years of planning. They deliberated for 3 days. They assimilated all the information from these committees and their conclusions for about 3 months, 4 months afterwards, and then published it in each of these new diagnostic and updated definitions. Particularly, what was most interesting to me was the new definitions for implant disease and implant health. And for the first time ever, really, we'd seen a formally recognized peri-implant soft and hard tissue category. We had all seen these types of manifestations before in practice, but we didn't have a whole lot of well-established literature about what are some of these conditions, what is the etiology behind them. And I really like this article. It was published by Hammerly and also Dennis Tarnow of New York. And they did a really good job of kind of breaking down these various lists of peri-implant soft, hard tissue conditions that exist both before and after implant placement. And you can see just a short list of some of those here, but very specifically for the first time, they're recognizing and defining that bone height in the posterior maxilla within proximity to the sinus floor is significant, and it's a treatment planning consideration that you need to respect. And so going back to the case here, if we look at the pneumatization of the sinus, we look at the level of the crestal bone, we know we don't have enough to appropriately place biologically appropriate and biologically sized implants here without additional help. Right? We've got resorption, pneumatization. We know we're going to need to gain more bone height to put ideal length and width of implants there. And so if we look at historically what are our two procedures we relied on, they were first discovered by Hilt-Tatum, later published by Summers. We saw the internal or the closed sinus lift, and then we also saw the advent of the open or lateral window lift. And so this is a particular set of techniques where first we try to minimally invasively prepare the implant osteotomy, green stick fracture the floor, place the implant sometimes with augmentation at the same time. Or if you have more extensive needs, as we'll go through in a little bit more detail here coming up, if you need to create that lateral window, you can enter the sinus and place a significant amount of graft. I'm not going to go through this entire slide, but this actually represents a culmination of about 2 weekends of CE and teaching from our textbook of the different various conditions that can compromise or contribute to the success or failure of implants in the posterior maxilla. Just briefly to summarize, the things that we look at for favorable versus unfavorable conditions include the quality of the bone. We know that in the posterior maxilla, often the bone quality is not quite as favorable, right? We consider that D3 or D4 bone quality, that softer styrofoam or balsa wood. Some of you remember the qualifications of Lacombe and Zarb when they talked about bone density. If we look at the patient's force factors, one of the things we like to say at the Institute is you don't treat implant a 300-pound linebacker the same way you treat implant an 80-year-old grandmother. They have different force mechanics. They've got different bone metabolism. There's other health risk factors that may be in play, like metabolic issues of osteoporosis. And so these are things that we think about with force factors. We also look at the opposing arch. Is it opposing a denture, an implant, or a tooth with a periodontal ligament? We look at the absence or presence of parafunction, like clenching or grinding. And of course, also the crown to implant ratio. What does that look like here? And so you can see the different designations. The longer the crown implant ratio, the more force. Remember that case I showed you with the seesaw, with inappropriate bone on both apical and coronal to the implant. And so this is one of our nightmare patients. They come in, you see all the bruxism going on there, those non-carious lesions. We don't know where to start with this. Sometimes they need full reconstruction. So just to kind of briefly show you what are some of the framework that I like to use, this was our criteria that we published in the MISH textbook. We have 4 different categories of what we call the subantral or SA classifications. Very briefly, if you have a perfectly ideal ridge height, we're talking over 8 to 10 millimeters with all those favorable conditions I just showed you. We'll typically consider placement of the implant without any additional sinus modification. Our SA2 or subantral 2 category, you can see if we have sometimes more than 8 to 10 millimeters, but within that range, and we'll consider if they have less favorable conditions, maybe placing an implant with conjunction of an internal sinus lift. And then we extend the healing time because there's augmentation present. When we get to the more complicated issues, if you have 5 millimeters of bone, sometimes a little bit more, we're now in that subantral or SA3, and this is where we do need more significant bone techniques to gain height. And so sometimes you can get away with doing a crestal or internal lift. It does push the technique, and I'll show you a little bit more about that in a moment. Or we could consider a lateral lift, and usually we can do this in conjunction with placing an immediate implant that day. And then the most significant issue would be if you have that SA4. If you have less than 5 millimeters of crestal bone height, then we'll consider conducting a delayed protocol where we'll place the augmentation first and then the implant later after a significant healing period. We know that the sinus techniques for grafting can be very predictable because it essentially represents a 4, sometimes 5 wall defect like this. And so we know historically when we socket graft or augment a socket after a tooth extraction, in most cases it's very predictable if you have 4 to 5 walls of bone. When you start compromising that or losing walls of vascularity, it does get a bit more complicated. So remember, the sinus can be predictable because it's completely contained most of the time. You've got anywhere from 3 to 4, sometimes up to 5 walls of bone. I also like to make sure we use very predictable regenerative products. It's been shown in the literature if you have a combination of cortical, mineralized and demineralized, if you use them together, usually the preferred rationale for that is that you're taking advantage of both osteoconduction for these mineralized components and then osteoinduction from the demineralized processing if you have exposed bone morphogenetic proteins or BMPs. Right? We're looking for growth factors and mitogens. So you can take advantage of putting these two products together in the sinus to help propagate a really great and really strong regenerative response. So these are the products that I particularly use in my practice. They've served me really well when we use that combination technique. So a little bit more on the internal crestal technique here. You can see this is one of the older or more traditional methods where we're using osteotomes. We're basically using a small mallet. Some of my colleagues actually had their assistant use the mallet and they would hold it in place. Their rule was the mallet never comes above the shoulder when they're hitting the osteotome. So as you can see here, you can control the force if you're very careful and conservative with how you place it. And so traditionally, as I mentioned, we use osteotomes in a mallet. There are other systems out there nowadays that are a bit more innovative that rely on hydraulics, balloons. So those can be something that are interesting that I'll show you in a moment. And just as a reminder, if you have that SA2 classification, you want about 1 to 2 millimeters of bone height or crestal gain from a superior to inferior aspect, and then placement of the implant. If you push the technique a little bit, you can gain more bone. So we're looking at a gain of 3 to 4 millimeters of height. However, it's important to understand that in the literature, we have seen significant incidence of larger issues with perforation. So anytime you have to gain anywhere from 4 to 8 millimeters, at least according to this study by Dr. Reiser, you increase the risk of perforation by about 25%. So 1 in 4 is pretty high odds that I don't necessarily like to take, but that's just me. So that was the internal or crestal approach. Now, if you are going to push the technique, there's other protocols depending on kind of what criteria you subscribe to. The idea is you drill the osteotomy short of the inferior floor of the sinus. You can often place collagen barriers. Some clinicians like to use PRF, and then placing bone graft or augmentation of some type before placing the implant. So that's typically the technique you'll use if you want to gain that 3 to 4 millimeter height of bone. Sometimes clinicians will just green stick fracture and place the bone superiorly and then place the implant without any additional augmentation. So here's showing an example here of, you can see the left posterior maxilla. This was kind of a unique situation where you have different levels and different classifications of SA2, SA3 sinus categories here. Our treatment plan was to place 3 implants there. You can see our radiopaque markers. One of the unique things and the nice things I like about this case is we start off with an SA1 category here, plenty of bone. Then we have the SA2 category here where we need to gain maybe 1, maybe 2 millimeters. I don't have the third cross section up there, but you'll see with the third implant, then we had to even gain some additional bone there. So drilling our osteotomies short of the sinus floor by at least 1 millimeter as measured on our CT scan. I chose to place some collagen plugs here like the Cytoplast RTM plug. We'll place that first just to kind of protect that Schneiderian membrane. We then placed our mineralized, demineralized graft, and then ended up placing the implant. So we use the techniques of the various osteotomes. Conservatively control the force that way, and I was able to go on to place, this is back when I used to place the trilobe. We've since switched to the conical connection in our practice, and we chose to place them as a delayed protocol with cover screws and then go back later to have them restored. So this is by my colleague down in Renton. And so you can see there, if I draw a line radiographically when I really kind of manipulated and played with the contrast to determine where the bone gain was. We gained about 3 millimeters of bone height in the most posterior aspect there, about 1 to 2 millimeters in that central implant, and then in the anterior implant, I really didn't do any lift at all. So you can see various aspects of those SA1, 2, and 3 categories. Okay, so that's our internal lift. That's an example of a case there. Now, one of the issues with this that's been kind of controversial is that there are case reports of what we call a benign paroxysmal vertigo. Essentially, if you're taking them out, you're banging on a peg that's in a patient's head, there can be some risk associated with that. And so it's been suggested that, some patients that come into an ENT clinic or their physician after they have this procedure and they're dizzy, they have issues with being able to regain balance, their vestibular stents is thrown way off. Well, some of the ossicles in the ear can be affected, right? And because you're creating blunt force. So again, as the rule of the mallet doesn't go above the shoulder when you're doing this, okay? And so that also begged the advent of additional techniques or other ways to try and do this conservatively. What you're seeing on the left side here is an example, and We'll try to actually have a couple of eggs set up if you want to come by the booth Saturday if people want to try this. But essentially, they have these side cutting burrs that are very minimally invasive. Instead of using a mallet and osteotomes, nowadays we have different types of drills where we can conservatively remove bone, and because they're side cutting, there's less of a risk of Schneiderian membrane perforation or separation. We've used various plungers, and you can see on this egg here, it's not something that was hard boiled. It definitely was indeed a really good exercise just to kind of practice for those of you that are just starting to get into sinus lifts. And then there's also various hydraulic systems where there's water pump systems that we can use in these cases. And I'll show you an example here where this is one particular manufacturer. There's Salvin's one example that makes these types of systems. This video I'm about to show you was actually provided to me by the Institute of Dental Advancement, where I teach out of Texas. And this was one clinician that's showing the demonstration of using various side cutting burrs. They're doing their osteotomy first. They know that they're fairly close to the sinus floor. And so we actually, at this particular surgery, had an otolaryngologist that had a scope, and he went into the sinus so you could see the lift being performed at the same time. And so you can see initially here, once we're using that hydraulic lift, it's basically just a little pump with a syringe and water. You can see how nice and conservatively it really expands that Schneiderian membrane. There's a lot of give if you do it conservatively with hydraulic pressure. And so just some examples here, kind of stretching the membrane. There you can see the little plug where we use the syringe. Then they're going back in with that internal crestal approach here. They probably placed a collagen barrier in this case, and then we're placing particulate graft. They're very carefully using a set of very customized pluggers in this case. What I like to say is some of the companies that sell these, I think they just took an amalgam plugger, they repurposed it, and they marked the price of about 10%. So anyway, showing you here basically placing of that augmentation. Right, again, I like a combination of both mineralized and demineralized. And then you can see the final picture over here. So I don't know if the light washes that out a little bit. You can see that the membrane's been able to be raised pretty significantly here, and we didn't have to create a window through the side of the sinus. So again, this is an example of how we're able to push that technique of internal and crestal approaches a little bit more with conservative technology. Now, if we get into the more significant consideration, the SA3 and SA4 classifications, we're creating this lateral window situation. This is where you actually cut an osteotomy on the lateral side of the sinus. So we'll manage an osteotomy. Usually it has to be large enough to get instruments in there, so anywhere from 8 to 10 millimeters wide by high. We're typically wanting to gain at least 5 millimeters of bone or more, according to at least our guideline classifications. The nice thing about this is you have direct visualization. It's typically important when you have situations of septa, for example, if you have to negotiate around those. Also, if there's a perforation or separation that happens, you're able to see it directly. You can manage it. Keep in mind with that closed technique I just showed you, you don't know if you're perforating or not. Some people say they can claim by maybe feeling it, but to be honest, I don't think that's always the best and most accurate way to tell. So sometimes you're just blindly putting material in and you have no idea if you've separated a membrane. And the problem is if you have a perforation or tear, we have seen in the literature the regenerative response we get isn't quite as robust or not as favorable. So this is showing a lateral approach here. There's various techniques to do that. The protocol we've published is a layered technique where we'll green stick fracture that bony window in. Superiorly, we're going to place a collagen barrier that's hydrated typically in some type of pure IV solution antibiotics. We like to use cephalosporins. And then in addition to that, we're going to place our layer of allograft or sometimes xenograft, or we like to mix the two of those together, mineralized and demineralized. For those of you like PRF or PRP, this can be an area where it's appropriate, also antibiotics. And then we'll have our inferior space layer where we'll decorticate or create that regional acceleratory phenomenon or scraping the floor of the sinus for angiogenesis. If you have the opportunity to harvest some autograft, that's a really great opportunity to place it there close to the vascular supply to serve as a spark or a signaling mitogen for better regenerative responses here in the sinus. So those are our different layers there. So just showing some of the steps to create that osteotomy lateral window. We infracture the floor, use various curettes to conservatively raise that membrane. We're going to place our collagen barrier at the superior aspect soaked in antibiotics. So we created our space there, placed that collagen membrane. We then created enough space so we can place our graft, again, a combination of mineralized and demineralized. So there's our collagen with antibiotic. Placing our layer of bone graft here. And I'm going to show you a video on the right side here. This is one of the demonstrations I'll show more in detail on Saturday. We'll have a typodont that actually has a sinus that's been created. And you can see various side cutting burrs here. And so again, we're going to create this opportunity so we can place that layered approach. So again, using various side cutting burrs here, we can create our osteotomy window. The nice thing about this is, again, it's very conservative. Even if you perforate through the bone, it has a very low incidence because of the high surface area to not perforate that Schneiderian membrane. We have a couple of different sizes. Again, you typically want to make the window large enough so you can get the hand instruments in to elevate that membrane. And so we'll have a couple of these drills available for people to see that Saturday. And we're going in somewhere between 800 to 1,500 RPMs with our implant hand place. It's typically done with irrigation, sterile saline. And then we'll take our hand curettes. We're also going to have some of these available during the demonstration. You see how we go in and initially release that membrane circumferentially around the window. We want to make sure that the sinus membrane is intact. We have larger and wider curettes that have broader surface area. We start with small surface area first, tiny instruments, and then go up from there. And if you want proof of principle, again, here's that egg demonstration using that lateral side cutting burr. Great surface area, low risk for perforating that membrane. There's various companies that make this. And so as you can see there, just practicing on the egg. And so when we perform this technique, I'd mentioned the protocol of layers, right? And so we'll rely on barrier membranes to protect the Schneiderian membrane and also to protect the external surface of our osteotomy once the graft has been placed. We borrow these barrier membranes from traditional periodontics. We used to have natural defects around teeth. We would clean out the defects. You have to contain the space. You want to exclude the faster growing epithelium. And the idea is if you can contain that cleaned and decontaminated space, it allows the various tissues of natural teeth to grow back. So you'll get a redeposition of the osseous architecture, periodontal ligament, even cementum. But when the tooth is missing, when we're working in the sinus, we still have to exclude the epithelium because it's faster growing. It can be invasive. It can grow into that sinus window. We also want to make sure we place a barrier at the superior aspect of our sinus lift because there can be perforations and separations up there that we may not always be able to visualize or see. And so it can be very protective to at least repair that. And so there's various options for resorbing barriers. I don't recommend non-resorbing barriers in these types of cases because it would be, as you might expect, hard to go back in and retrieve it. These are the 4 different categories of bone augmentation options that we have. Traditionally, it was thought of as the gold standard to use autograft or bone harvested from the same individual. If we have the opportunity to do so in these types of cases, it can be a really great benefit. Typically, we place it in the floor of the sinus according to our protocol. Much more predictably nowadays, we have these great allograft and xenograft options to rely on. It's been FDA approved. The allografts work really well. Again, we've got mineralized, we've got demineralized. I like the demineralized combination into the mineralized graft because, again, you can get both osteoconduction and osteoinduction. And one of the ways that we like to also do this is with the xenograft particles because they're actually very resilient. They do take a little bit longer for resorption, but with the sinus, you're waiting anywhere from 6 to 8 months, sometimes up to a year for it to heal before you place the implant. So currently we have 3 FDA-approved sources from a cow, pig, and a horse. They're all very predictable. Personally, I like the bovine-derived grafts. Some clinicians tout and use the alloplast or the synthetic. They do have a much more significantly longer resorption time. And so I try to shy away from these unless there's a specific personal or religious or cultural conviction by the patient. And so if we look at an example here where we're going to be performing a lateral lift, this is what I considered an SA3 category. I knew I needed to gain at least about 5 millimeters of bone. And what we do is we treatment plan where the implant's going to go. You take the lowest point in the sinus, and that's where we get our classification from. So that we know that when we perform our osteotomy here, this is just showing a video on an actual live patient. Again, using that side cutting drill, 800 to 1200 RPMs with sterile saline. You can see the Schneiderian membrane there exposed. It's very well intact. Then we can go in with our hand curettes, and we have various different surface areas and sizes to be able to do that. Very carefully, you want to lift that Schneiderian membrane. And the most common mistake that I made early on in my career was not going anterior and inferior enough relating to reflect that membrane. So you want to make sure you completely reflect it all the way to the anterior inferior and all the way to the medial wall of the sinus. Here's showing another example here, manipulating our membrane. We use the Creos Xeno Protect. It's a longer lasting barrier. Usually I like my membranes to last at least 6 to 7 months when we're doing these types of techniques because if there's a perforation, I want to keep that graft protected. I don't want any particles getting up into the sinus cavity. Now, once I'm completely confident the membrane is tucked up and everything is covered with that Schneiderian membrane, I'll often use a probe to kind of measure and just check, make sure I can feel the medial wall. We can also calculate surface area that way. Once I know that membrane's protected and raised up, then we'll proceed with our immediate implant placement. So we place the osteotomies here. You can see some examples of that, checking our positioning with our force position indicators or our guide pins. You can see here I've confirmed that we are indeed in the right position, right up through the center of that sinus area. And of course, if we tried to cheat the implant a little to the left, maybe we could get away without a sinus lift, but then biomechanically we're in the wrong position. It's harder to restore. We have proximity to the adjacent tooth. And so here's finishing up our osteotomy cycle. We decided to eventually move all the way to placing an RP implant. On the left video here, again, we're placing our combination of our xenograft mineralized and our demineralized allograft. So I like the Xenogain and the Allogain products, so we can mix together for those. I often like to try to use one of these syringes, as you can see here. It makes it a little easier than having to scoop the graft in one at a time. It doesn't quite take as long. And then we'll use our various curettes to gently compact the bone into that window. Once we feel like we're predominantly full, then we'll actually go ahead and place the implant through the osteotomy. And so I like this because it really compacts the bone around the implant threads. I think you actually have a higher bone implant contact afterwards if you have pretty good dense compaction. And so as I mentioned before, I do like the mineralized types of products. So for example, the Xenogain, we know that's a bovine matrix. It's mineralized. It's got really good particle size, anywhere between 200 to 1,000 microns, which are actually considered in the research fairly ideal for angiogenesis. If the particles are too small, it's packed too dense, you can't get angiogenesis into the site. We want it to be hydrophilic because we do want all of those potential cells to come in and basically perform their breakdown and buildup, right? So we want the osteoclast and osteoblast to migrate into that area, consume this graft, lay down new bone, and we can see histologically we do have great contact between the graft particles and native bone, and we have good turnover over time. And so this is just an example of that product. And then of course, as I mentioned, I do like to mix it with demineralized for osteoinduction. So using a demineralized cortical product like the Allogain is something that is very predictable with that osteoinductive ability. So once we have the implant sinus packed, we place our implant. In this particular case, I chose to place a healing abutment. Some clinicians will choose to do a delayed protocol depending on their initial stability. So that was that SA3 category. In the last couple minutes I have left, we'll show you this SA4, right? When you know you want to have at least 5 millimeters of bone, and you anticipate you're probably going to need to place the implant with a delayed phase. And so this particular phase here, we see that there's very significant atrophy. There's pneumatization. We know we're going to have to get significant gain of bone there in order to place the implant. And so this is just showing our lateral entry there, our full thickness mucoperiosteal flap. We create our osteotomy. Now in this particular case, I was using a straight handpiece with small diamond burrs. That's another method people choose to use. Creating that window, placing our collagen barrier membrane superiorly first, soaked in antibiotics. For this particular one, I guess I also like the long-lasting RTMs, so we can go for a cross-linked collagen barrier membrane that lasts at least 5-6 months. We placed our graft after doing our osteotomy. In this particular case here, I used ampicillin as a pure IV solution antibiotic to mix with the graft, and that's something we very commonly do, especially if the patients don't have allergies to them. We do our layered technique. Now in this particular case, there was a very significant mucosal defect that was also there that I wanted to try to address. We wanted to increase the biotype in this area. And so one of the nice things is if you can use an acellular dermal matrix on the external layer, you can actually enhance the biotype thickness, because we have seen with studies by Linkevicius' group that if you have thin mucosa, if you don't have enough thickness for that mucosal protection around implants, it does predispose to a higher preponderance of peri-implantitis and bone loss. So using the acellular dermal matrix like this, the microderm product is what we use in our office, we can enhance the biotype and at the same time protect the graft and increase the collagen protection around that site. And so one of the nice things about this is you're actually accomplishing a couple of things at once. So you can see primary closure there. We've got this really robust gain of bone volume, really robust gain of tissue quality and quantity. This is what it looked like several weeks later when we removed the sutures. Radiographically of just taking a PA, you can kind of see there's very significant gain. We would go on to take a new CT scan, so if you just see pre and post-operatively, we've gained height. We know we've gained volume and dimension because we've filled that sinus at least 8 to 10 millimeters in terms of height. And so after 1 year, we chose to see the patient again, and then they will move on to have the implants placed with a delayed protocol. So that's an example of the SA4. So in summary, we've talked about the lateral versus the crestal approaches here. With the guidelines that I've had here and some of my personal opinion, when we have a situation where you have about 5 millimeters of bone, we need to gain more significant bone with techniques that we have available. So if you have less than 5 millimeters of bone present, you're probably going to want to rely on a lateral sinus lift and maybe a delayed protocol, that SA4 scenario. If you have about 8 millimeters of bone or more, you're probably okay with an internal crestal sinus lift and implant placement at the same time. It, of course, also depends on conditions. I'll stick around for questions after. And then if we have kind of this gray area, 5 to 8 millimeters, this kind of, in my mind, designates a borderline situation where you have to use your best clinical judgment. Look at all the patient's risk factors. Look at what the bone quality is. What's their metabolic bone health like? Will you be okay with doing an internal lift and maybe pushing the technique a little bit and placing an implant? Or maybe you need to rely on a lateral window and an immediate or delayed implant placement. So that's just kind of how I process and think about some of that criteria. And so again, I just remind you and I invite you, if you want to come by the booth on Saturday, we're doing a demonstration. I might even have some hands-on opportunities with eggs and the sinus burrs. It will be at booth 305. If you want to get in touch as well afterwards, I'll stick around for questions for a few minutes. There's my email. I also try to post cases and things I think are interesting on Instagram. I just got into it, so don't be too harsh on my profile. I literally started it like 2 months ago. So, and we're at Puget Sound Periodontics, so we are available in the community if people ever want to come and collaborate or if they want to even just observe for a day. So thank you very much. I can stick around.